Topic of the lecture today is human papillomavirus infection. Now, in this lecture, we're going to talk about what human papillomavirus is and how it causes an infection in our body and how does it manifests. But first of all, we have to start with human papillomavirus. I have to explain in detail what human papillomavirus is, what are its characteristics, and how do we differentiate it on the basis of its types. Now, first of all, it belongs to a family of Papilloviridae. That's the first thing to remember. It belongs to a family Papilloviridae. Next on, the second point you have to remember is it's a double-stranded DNA virus. It's not single-stranded RNA, it's not double-stranded RNA, it's double-stranded DNA virus. Number 3 is that it is further subdivided into 130 to 140 further subcategories. There are 130 to 140 subtypes of human papillomaviruses. And number 4, it is covered by a cascade of proteins. It is not covered by some capsule. It is not covered by something which is remotely related to any membrane, but it is covered by cascade of proteins. Now, 3 of them are very self-explanatory. That okay, it is covered by a cascade of protein. It is double-stranded DNA virus, and first of all, it belongs to a Papilloviridae family. But one thing that needs explanation is it contains 130 to 140 subtypes. Now, among those 130 to 140 subtypes, on which basis they are divided, on which basis they are given their type number? They are divided on the basis of their pathogenicity. They are divided on the basis of their action. Now, human papillomavirus can infect and affect squamous epithelium, metaplastic epithelium, and even surface epithelium. So their subtypes, the subtypes assigned to them are actually giving away the information that what area does this human papillomavirus targets and what area does this human papillomavirus will infect and affect. Now let me give you some examples of it. There are basically 2 specific subtypes which are low risk, which is 6 and 11. These 2 subtypes are very low risk and they have only one pathology to cause. They cause genital warts. They cause painless genital warts and they don't have anything else to do. They'll just go away if you treat them. If you treat those warts, they'll go away. They don't cause any pathology anymore. But then comes what? Then comes those human papillomaviruses or those subtypes of human papillomaviruses which are very much oncogenic in nature. I hope you know what oncogenic means. It means that if it's not treated, it will lead to cancer, or they have higher probabilities of causing cancer in both males and females. In females, they cause cervical cancer. In males, they cause testicular cancer. They cause anal cancer, rectal cancer. Anorectal area is affected the most in this pathology. So up till now, we know that there are low risk HPVs. Low risk HPVs are 6 and 11. Let me tell you some names of high risk HPVs. High risk HPVs involve 16, human papillomavirus 16, 18, 21, 29, 35, 45, and it goes on. You just have to remember 4 or 5 to describe in your examinations. So high risk HPVs, once they infect your body, they're going to stay here. They're not going to go away. And the biggest problem with this pathology, which is that it is not symptomatic. It is asymptomatic. You won't even know that something is brewing inside your body until you get to the cancer stages. Until you get to CIN1, CIN2, CIN3, CIN4 stages of your cervical cancer. So if you don't know that you have any pathology, you won't consult a doctor, you won't go to any doctor, and it will go on. You will feel healthy until, boom, you have CIN3 cancer of cervical type. So how will you know? There's no way of knowing, but that's why we have developed screening processes that women who have been involved in more sexual courses with strangers whom they didn't know, they should get screen, because the main method of transmission of this disease is sexual. You get in contact with that person who has genital warts, you get in contact with that person with a cervical cancer, you are definitely exposed to this now. Now, after knowing, we have stated like many major facts at human papillomavirus, because it is very important to get the main idea of human papillomavirus, and then you're going to learn about how does it cause infection. I want you to learn these things that up till now we have learned that it is double-stranded DNA virus. It is covered by a cascade of proteins. It belongs to papilloviridae family. Next on its types, there are low-risk types, there are high-risk types. Low-risk are 6, 11, which cause only warts, and then comes high-risk, which are 16, 18, 19, 24, 25, 29, 35, 45. These are high-risk types. Now, these high-risks also affect your, also cause wart, but they can gain entry into your system. They affect the anorectal regions. They can go up to your cervix and cause cervical cancer. And among them, 16 is the highest risk type of human papilloma virus. Now that you know about low risk, now that you know about high risk of them, you will understand as we go along that which of those types are causing these pathologies, right? So let's talk about the transmission and pathogenesis of this pathology and pathogenesis of this organism, this virus. So first of all, let's talk about transmission before going on to what's going around here regarding pathogenesis. Let's talk about transmission. Transmission can be caused by getting in contact with that person which already has this pathology, which can be anyone, which can be any person who has genital wart, which can be anyone who has some kind of anorectal area affected because of human papillomavirus. Now, among those 130 to 140 types, 30 to 40 types of HPV only affect the anorectal region. That tells you the severity of it. That tells you that only 30% is going to only affect what? Your anorectal region. So that in case you get in contact with such a person, and that contact may be only a touch, maybe only change of saliva, maybe only sexual intercourse, all of these will lead to what? Will lead to transmission of that organism into your body, transmission of that organism in your cervix. And once you've got this organism in your cervix, once you've got this organism in your anorectal region, once you've got this organism on your skin, what's going to happen? Now, this diagram is a depiction of cervical cancer, right? So we will tell you that pathogenesis regarding cervical cancer, how does that happen as we go along? So first of all, what happens is that HPV infection happens. Infection by HPV comes in, right? Now, the very basic rule for HPV infection is you must have seen a lot of people coming with warts which are on hands, on the sole of the feet. Now, what happens is that whenever there's a break in the skin, those HPVs are going to make their way into the basal layer. This is the surface, this is the basal layer. At the very end, at the very base, as there's a break in the skin, they will go directly to the basal membrane and they'll incorporate themselves into it. When they incorporate themselves into that basal membrane, what will happen? When incorporation has already happened, they will propagate, they will distribute with the basal membrane. Now the basal membrane is infected. Now the basal membrane is affected. Now that it is affected and infected, it will multiplicate with the basal membrane. It will come on to the surface area. And here comes the wart. Here you will see the wart. That's for your sole of the feet. That's for your other areas which are affected by wart. It's not about cervical cancer. I'm just telling you how does it work. It affects the basement membrane, the basal membrane. Now that it affects this area and these cells start distributing and come up to this level, you can see all of these cells are now not normal. They're kind of mutated cells. They are cancer cells now. So they are mutating, they are replicating, and at the same time, there's no body function that's going to suppress them or kill them. Why? For that to learn, we'll talk about it in the next slide. How does it kills all those processes which are responsible for killing it off. So infected basal cells comes in, infected basal cells. Now infection by HPV infects epithelial cells in cervical mucosa. HPV DNA integrates into the cellular genome when causing cancer. We've talked about it. It will go down the basal layer. Into the basal layer, it will incorporate itself. It will do this DNA integration, cause these mutated cells, cause these cancer cells. They'll start replicating, they'll start dividing, they'll come up to the surface, and more cells will be producing. And up till some point, it will be a cervical cancer. It will affect so many cells, or it will affect such a region that you might say it's a cervical cancer. Now, at this stage, when this basal layer is being affected and DNA being incorporated or integrated, what happens is that they are dividing, viral replication is happening along with it. It takes only weeks. Now, after this happens, after this is done, what happens? These viruses are given away. These viruses are given away because there are a lot of viruses. Those viruses will travel up to the certain level and cause a pathology there. So it's transmitting itself in the body. It does not need anything else to transmit itself in the body. It's transmitting itself. So HPV and epithelial cells will come in because in the very early stage it was in basal cells. Now epithelial cells are affected. And what will happen afterwards? Now 90% heal within 2 years. How? That's where our tumor marker cells come into play. We've talked about P53 genes. We've talked about all those tumor suppressor genes like E2F factors. All those suppressor genes come into the play. They recognize there's a pathology here. They recognize these cells are not normal. These cells are cancerous. And they will stop their replication in the cell cycle. They'll stop their division. They'll stop this whole phenomena. They'll kill off these cells. And that's how in 2 year time, you get all right, everything is all right. But why does it take so much time for our tumor marker cells to identify these cells? That's a question which is still unanswerable because in the very early stage, it's not even there and you cannot even diagnose it. It incorporates itself in the cells. You won't be able to differentiate them from the normal cells. But with time comes a differentiation, and with time our P53 genes and E2F genes, they'll come into the play and they'll kill off this organism. And in 2 years, 90% of those patients heal. But what happens to the other 10% of the patients? Those 10% of the patients don't heal in 2 years. This pathology goes on. It takes 10 to 30 years. It does not happen overnight. It's a very slow organism. It does not replicate on its own at a very high speed. It takes a lot of time. So in 10 to 30 years, you will have this cancerous cell. You will have this invasive cancer. So this is all about pathogenesis of it. This is all about how it gets to our body, which layer it affects, and how much of these patients which are affected by them get better on their own. Our immunity is responsible for that. Our tumor markers, tumor suppressor genes are responsible for that. But how many of them do not get better and lead to invasive cancer? That's about 10%, and they need 10 to 30 years for it. Now, HPV DNA integrated into tumor cell DNA. As you can see, HPV DNA is incorporated into tumor cell DNA, and that is what is actually the basis of this developing cancer. So 0.8% develop cancer in it. Next on to the pathogenesis of it, let's talk about the cell cycle, right? We've talked about cell cycle in every lecture we have gone about. In every lecture we have talked about cell cycles, that how does it go, at which stage tumor suppressor genes are working, at which stage tumor suppressor genes are not working, which organisms are stopping tumor suppressor genes, which organisms are enhancing their functions. So let's talk about the pathogenesis on the basis of cell cycle now. So we know that there are 4 stages basically: G1, S phase, G2, G0 phase. We talked about it. So what happens is that we have these 4 stages here: G1 stage, S stage, G2 stage, M stage. We all know what happens in these stages, right? In G1 stage, cell is getting ready to replicate. Cell is getting ready to synthesize DNAs, and in this stage actually cell is getting ready. It's actually accumulating all those things which are required. It's gathering all those things which are required for replication. At that stage, synthesis happens. All those things which are required for the development, they are synthesized, like mitochondria, like all the other cell structures which are responsible or which are needed, they will be synthesized. In G2 stage, they'll make these spindles, they'll get ready to go under mitotic activity, and at M stage they go under mitotic activity and they divide into two cells. That's what happens in a normal cell cycle. Now, what will happen in this cycle? Let's talk about first normal. We know that after G1 it go into S stage with the help of what? With the help of cyclin D and CDK4. Now, these elements or these things which we're going to talk about, we have talked about cell cycle in detail. In many lectures, you can go back and view that lecture in detail, that how does a cell cycle go along and what factors are responsible for converting from G1 to S stage, from S stage to G2 stage, from G2 stage to M stage, and from M stage to G1 stage. So in that lecture even, and in this lecture, we're talking about the G1 stage to S stage is done by, or it is carried out by the function of cyclin D and CDK4 cells. Now, P16 is the one inhibiting them. P16 can inhibit their function, and that's why it's there with this line. It means it can inhibit their function. Now, here phosphorylation happens and gives off what? Retinoblastoma, which is RB, and E2F is released to this retinoblastoma. Now, these are factors which are responsible for stopping this tumor suppression, for stopping this process in its very birth. If they have somehow identified there's a cancer cell, what will happen? They will do all of this process and they'll identify that cell cycle and they'll put a stop to it. So what happens afterwards? Stimulate cyclin E, and after the stimulation, what will happen? And after the stimulation of cyclin E, what will happen? This cell cycle will be stopped at its birth. On the other hand, before phosphorylation, what happened is that retinoblastoma and A2F, they were in contact, they were together, and this is what was leading to the synthesis of DNA. But if E2F is released, stimulation of cyclin E will happen, and this also leads to a synthesis of DNA. So we have talked about at G1 stage to S stage, the cell gets ready for synthesis. Cell gets ready for the synthesis of all those materials which are required for DNA synthesis. So these processes are actually helping them, and it's a normal cell cycle. Now what will happen so after synthesis of DNA, the cell cycle progresses. Now what happens in the abnormal cycle? That's what we are here to learn, right? That's what we are here to learn, that what's papillomavirus is going to do. Human papillomavirus is going to do what? We're going to talk about it. First of all, HPV-infected cells are going to behave in a very different way, because HPV release protein E6 and E7. Here it is written only E7. That's not right. It contains two basic proteins, E6 and E7. Now, what's their function? E6 and E7 proteins are ready, and E6 and E7 proteins have only one function. They go off, they suppress this E2F factor, they suppress this retinoblastoma, they suppress P53 factors. So they go on and suppress the tumor markers, just go on and suppress the tumor suppressor genes. So if they are suppressed, they won't be able to identify any problem with the cell cycle, and this cell cycle will go on. So HPV releases, human papillomavirus releases protein E7 and E6. You can write E6 along with it on your textbooks. So when they go on and it affect retinoblastoma and E2F bond, here retinoblastoma will only be attached to what? E7. Now E2F is released from it. When E2F is released, E7 binds to it. Those E6 and E7 protein, E6 might be detached, but E7 attaches itself to what? To our retinoblastoma. So this E2F is released here, right? Because retinoblastoma is attached to E7 now. So E2F is released. This bond was very important, and this bond had a significance that whenever E2F is released, it means cell is normal, cell is going on fine, and that E2F can go on and lead to synthesis of DNA and cell cycle can progress, right? So what this virus did, that it gave E6 and E7 bound to retinoblastoma, and it gave off E2F. Now that bond is broken, E2F goes on and increases the synthesis of DNA. That will lead to progression of cell cycle, and that will lead to negative feedback. Now, what is the immune response to HPV infection? We have talked about cell cycle, we have talked about the life cycle, we have talked about how it enters, which layer it affects. We have talked about basal layers are the first ones to affect, then epithelial layers get affected, and this goes on, right? We have learned about up till this point. But we've talked about in that slide, in the slide in which we talked about how it affects the basal layer, how it affects the epithelial layers, but 90% of those patients get totally fine in 2-year time. Now, to learn how those 90% patients get better with time, we have to learn the immune responses to HPV infection. That how did they get better? What happened along the way? How our immune systems helped in getting them better in 2 years time period? And what processes happened that did not help those 10% patients in getting invasive carcinoma? So to learn all of that, we have to know what are those immune responses which are responsible for HPV infection. So what happens is that we have this HPV infected keratinocyte. Now this HPV infected keratinocyte, it is attached to HLA class 1, HPV-P, all these proteins are here, and it is attached by what? Natural killer cells. These NK cells are natural killer cells. Now this can go along two ways. These cells can either identify them and kill them, they can lyse them, or they cannot identify them, and that will lead to a disease response, right? So let me tell you that if they recognize them, if the recognition pattern is on, what will happen? Lysis will happen, will lead to a healthy cell, and interferon gamma will come in, and their function will lead to a healthy cell. On the other hand, if there is no recognition whatsoever, if they are not recognized, if they're not lysed, if interferon does not come in and does not cause any kind of response, it will lead to a diseased cell. On the other hand, we have these LC cells which are affected by what? CD4 T cells and CD4 T cells, right? They are in contact with them. If they are being affected by or being recognized and affected by Th1 cells and interferon gamma cells, they will again lead to healthy cell. On the other hand, if they are affected by Th2 cells, they are leading to diseased cell. So up till now, in immune responses to HPV infection, we have learned that if natural killer cells recognize them and recognize their patterns and lyse the cell with interferon gamma, they will lead to healthy cell. On the other hand, if they do not recognize them, it will lead to a diseased cell. Same like that, if it is infected or affected by the interferon gamma and Th1, it will lead to a healthy cell. On the other hand, if they are affected by only Th2 cells, it will lead to a diseased cell. Now, clinical manifestations of human papillomavirus infection. Now, as we talked about different subtypes of HPV infection, we have talked about 130 to 140 different subtypes of human papilloma virus. Now, in all those subtypes, I told you that these subtypes are only there for on the basis of what? On the basis of their affected area, on the basis of what area they affect, on the basis of what membrane they affect, on the basis of what epithelium they affect, right? So the clinical manifestations of HPV infection will be different in every HPV infection. Clinical manifestations totally depend upon this fact that which area is being affected or infected in this scenario, right? But in this slide, we're going to talk about some very casual, you can say, or some very usual symptoms you come in contact with regarding the patients of HPV. What are those clinical features they are presenting to us with, like most of the times? First of all, HPV infects and lead to what? Female and male. In female, they affect what? In female, they affect vulva, vagina, and cervix. Now, you can see different kind of warts here even in the vaginal area. This is vulva, vagina, and cervix. These three are target organs for HPV in female. On the other hand, in male, they can either affect the urethra, they can affect the penis, and they can affect the scrotum. You can see these raised lesions, these warts present in the genital area, or they can go on and affect these structures in both. They can affect perianal region, they can affect the anal region, and oropharyngeal infections. Why oropharyngeal infections? Because of the oral sex. Because if a patient is being infected by this HPV and he has these warts and he goes for oral sex, oropharyngeal infections can come into the play. So up till now, we've talked about in females, there are three structures that get affected the most, which are vagina, vulva, and cervix. In the male, they affect what? Urethra, penis, and scrotum. These three structures, which are only present in one gender, are very common. Now, what areas it affects in both the genders? The areas being affected in both the genders are perianal regions, anal regions, and oropharyngeal infections. Oropharyngeal infections because of oral sex. Now, these are very important clinical manifestation a patient will present to you with. But it only accounts for 30 to 40 subtypes. I told you it has 130 to 140 subtypes, right? Only 30 to 40 subtypes are involved in causing this pathology in perianal regions, anal regions, and scrotal regions. Other have different pathology, have different consequences, like they will lead to wart in the sole of the feet, they will lead to wart on your face, they will lead to wart on your epitheliums, different epitheliums. They can go up to your cervix and cause different pathologies. So its clinical manifestations are rather very stretched out based on the type of HPV infection we are having. Now, other clinical manifestations will involve what? They involve genital warts, they will involve penile warts, they will involve keratotic plaques, they will involve vulvar warts, they will lead to vaginal lesions, and they will lead to cervical lesions. Now, three difficult words are being described here, and I'm going to describe one of them, which is wart. What is wart? Wart is actually the very early, you can say, very early description, very early diagnostic modality for getting to know that, okay, there's HPV-2 or HPV-6 present in our body. Whenever there's a break in the skin, these HPV-2 or HPV-6 will come into the play. They'll go down they'll cross your surface epithelium, they'll go down to the basal layer, they'll cause this pathology, and with time they have incorporated themselves in those basal layer cells, they will divide and replicate, and up till some point they will reach the surface, and from surface they'll reach to raised lesions. Those raised lesions are called warts. They have a white base. You can go for all the diagnostic modalities, but they'll only tell you have HPV infection. So you have these warts, you have these keratotic plaques, which will be caused afterward warts. You can have vaginal lesions, which come into the play after getting the warts, and cervical lesions. Those cervical lesions will lead to cancer if they're not treated or if they don't get better on their own in 2 years time period. Now, prevention of HPV infection. How do we prevent people from getting HPV infection? Now, before heading on to the HPV vaccine part, So what we have to do to prevent HPV from spreading is very simple. We have to get those people screened every 3 to 6 months, or at least yearly checkups should be done of those people who get in contact with those people who are not screened, or those people who have more sexual intercourses should be screened, first of all. Second of all, if someone has this pathology or got this disease, he should immediately report to the hospital rather than treating these pathologies on their own, because many of the people will go on and try to treat these pathologies on their own, try to treat these warts on their own, go to homeopathic doctors and try to treat their pathology there. But we have to report it, and those patients should avoid sexual intercourses until they are totally healthy. But that's not a common practice in our system. Even a patient who is suffering from this pathology won't give up sexual intercourses. He'll keep on having them, and this will lead to transmission of the disease to the next person who is getting involved with the person. So these are very important preventive methods we have to carry on, we have to perform in order to avoid such pathology from in our body. Now let's talk about prevention of HPV infection on the basis of HPV vaccine. Vaccine has been produced to fight off this pathology. What two vaccines are there? There are multiple vaccines. There are not only two vaccines, there are 8 to 9 vaccines up till now that have been produced because of 130 to 140 subtypes of it. We have 130 to 140 subtypes. Not only one vaccine can cover all those subtypes. So we have produced 8 to 9 different types of vaccines. But in this lecture, we're going to talk about two major vaccines which are being administered all over the world and are having very good results. We're going to talk about only those two vaccines so that you might get a good idea of those two vaccines and you can remember them. First of all, we have bivalent vaccine, which is given in the name of Cervarix. Now, the name indicates Cervarix. It will be given to female patients basically, and in female patients, those patients which are having cervical issues or cervical lesions. That's why the name Cervarix is given. It is a bivalent L1 VLP vaccine which is given intramuscularly in the form of injection at months 0, 1 and 6. These are given at the month of 0, 1 and 6. This is bivalent vaccine. Now it is given at the birth, and it can also be given to those patients who are at higher risk of getting this pathology later in the lifetime when they are not vaccinated before time. Next on, we have quadrivalent vaccine, which is given in the name of Gardasil, and it is quadrivalent because it covers what basic HPVs? 6, 11, 16, 18. Now 6 is low risk obviously, but 16 is the highest risk HPV in the subtypes of HPV. So we have produced a vaccine against 16, 18, which are very high risk, 11, 6, which are low risk. But we have produced a vaccine which can be given in both the cases, in low risk HPVs and in higher risk HPVs. And this is a vaccine which is being used more oftenly these days. It is given same intramuscularly at the months of 0, 2, and 6. There's only one difference. It's given at 0 and afterwards 1 month. It is given at 2 months. Most of the patients or most of the parents opt for quadrivalent vaccine, which is given in the name of Gardasil. Next on, treatment options or therapeutic options. Okay, we have got our vaccination done. What next? We already have warts. What about them? How do we treat those warts? How do we treat those keratotic lesions we already got? You got us vaccinated, you told us what to do, we told us what not to do, but what about those clinical manifestations that we are having right now? For those we have therapeutic options, for those we have treatment options. And in treatment options, we have podophylotoxin. Now it is given in those patients which are having these raised lesions, which are having these pathologies, and podophylotoxin is given in uh, in anticipation that this will kill these organisms off and cause these clinical manifestations to revert back into a normal shape. Next on, you can go for synecticans, or some people call it synecticans. They are given in the tube form. They're the creams. You apply them on the skin. For example, you have genital warts. You apply them on genital warts, and they help them out. Next on, we have imicomycin, right? Now, imicomycin is given in the form of these drops, in the form of the tube. They are also very helpful in treating the warts. They're also very helpful in treating other skin manifestations like keratosis or keratotic lesions. Next on, we have cryotherapy. Cryotherapy is very helpful in those patients which are not getting any response from using all these three therapeutic options. They are given to those patients in which this lesion or this skin manifestation is rather very drastic and it is not being treated by any other modality. You go for cryotherapy. With cryotherapy, the results have been 80 to 90% in the favor of the patients. Next on, you can go for the surgical removal of such structures. You can go on for surgical removal, and surgical removal will lead to, you will remove all that area, you will remove all that membrane, but it must include what membrane? Basal membrane, because that's where they are hidden, that's where they are replicating from. So you remove the whole layer involving the basal layer. Next on, you go for laser. You can destroy these cells, you can destroy these viruses by projecting those skin areas to the laser, and laser will take care of them. Laser will kill them off because they cannot stand any heat. So laser will kill them, and that skin lesion or that skin eruption will go back to normal in a very small amount of time. Next on, you can go for interferon. We all know about interferon. What is interferon? Interferon is given to those patients who are having viral infections. It is the only antiviral we have up till now which is working in every field. So you go for interferon. One thing that is not mentioned here is that other treatment modality we have and most people go for is cautery. Now, cautery is told to and prescribed to only those patients who have warts on the sole of their feet, who have painful warts, who cannot stand the thought of warts anymore, who are suffering because of it. Cautery is told to those patients because with cautery, you can burn those lesions, you can burn those skin areas, you can burn out to the basal membrane and hope it will not happen again. Now, cautery is another therapeutic options that you have to keep in mind. But after using all these treatment modalities, there's always a chance of recurrence in the cases of HPV. That virus is somewhere hidden in some cell and you did not take care of it. It will replicate from there again. So recurrence is devastating for those patients who went through a lot of trouble like cryotherapy or cautery or surgery or interferon or laser. It's a lot of trouble for those patients, but you have to counsel the patient in advance that this can come back and we will have to take care of it again, so that when the recurrence happens, the patient won't be troubled or he won't even or he should not trouble you. Next on, we have counseling. We'll counsel the patients. First of all, the counseling will be regarding three basic points. We have to counsel them three basic things. First of all, we have to counsel them there's nothing to worry. We have vaccines available. We have therapeutic options available. We can take care of you. We can treat this modality. You don't have to panic. There's only minute chance of advancing this disease leading to cancer, but we won't let that happen, so the patient might feel at ease. That's the first point of counseling. Second point of counseling, you counsel them that you have to take care of yourself and your partner. If that person is married or has children, you don't have to get in contact with any other person. Not sexually, not share anything up till the point you are recovered. You will counsel the wife If the husband is affected, you'll counsel the wife that you have to stay away from him. You don't have to go for any sexual intercourse until this patient or this person is totally cured. That's for your own benefit. You will tell them all about these HPVs. You will tell them all about how they will get this disease from one another. So they will be very cautious afterwards. Number 3, the most important point for counseling, you have to tell them that this might come back again. This might come back again and we can treat it again so that the patient will be mentally ready if recurrence happens. So this will be all about counseling. You'll counsel them properly and afterwards you will be done with your part as a doctor. So that's all for today regarding HPVs. We have talked about what they are, how they are covered. They are DNA viruses. What are their subtypes, ranging from 1 subtype to 140 subtypes. We've talked about what are low risk subtypes, what are high risk subtypes. Now, these are the points you have to remember and you have to take away home from this lecture. You have to know about the subtypes of them. You have to know what are low risks, what are high risks. You have to know that what is the transmission mode, how does it go along its route regarding pathogenesis. You have to know in the life cycle which of those factors are responsible for leading to DNA synthesis, cell synthesis, and not stopping it. What are clinical manifestations regarding every basically every important HPV infection. You are going to remember what clinical manifestations they'll present to you with regarding your skin. You have to remember what treatment options or therapeutic options we have. You have to remember what vaccination options we have, and you have to remember how to counsel them. So that's all for today. Thank you for watching sqadia.com.